Hello, and we are live. So it says here. Um, yeah, let me just detach the chat. It's out, so I can hear if anyone comes online. I have about an hour until I have to go out to pick up my boys from English school. So let's grab a few scans. We have many today. So let's go. It's a inner ear scan, a temporal bone MRI. Just downloading. Need to copy and paste my template because I have a template for mostly anything. Internal auditory canals. And we have downloaded it. It's here. Yep. How is it to you guys? Yeah, it's working. So internal auditory canal usually has the same sequences as the brain with a larger field of view. So we can see smaller structures properly, smaller structures from the mastoids, the temporal bones, the inner auditory structures. This is a very poor exam in terms of image quality. It's done wrong, it's shaky, and it has a very low resolution, so this isn't supposed to be of use for a proper diagnosis. This is just make-believe. So let's see if we can notice any major disease, because tiny diseases won't be visible no matter, oh, this is just noise, no matter how I work them out. Shit. I won't even bother reading to you guys whatever clinical history has been communicated through the platform, because it makes no freaking sense, and I want to waste your time. Yeah, this is just a useless. Oh, and it was done unenhanced. So this is an unenhanced, useless exam. Let's just go over and report it as normal, because there isn't really much to see here. It's gone. I'm sorry you had to go through this. Let's go to the next exam. There is really nothing to see. Just a waste of time. So this is a lumbar spine. And I have seen a disease already. What about you guys? It says here, oh, I can't read because whoever wrote it wrote it in a way that it doesn't look like it's proper writing. So it's just impossible to figure out whatever is written in the request, exam request order. It says she has some kind of nerve root disease. It doesn't say on which side it is. They just say it is. So this patient is a female. She is only 19 years of age, and she is supposed to have a severe neurological disease of the lumbar spine. This is a T2 without fat saturation. She is quite fat, so clear signs of obesity right there. She is clearly obese. So let's look for inflammatory acute diseases, since it's very rare for such a young patient to have chronic degenerative disease of the spine. So it's either trauma or some acute disease that should be as painful as anything else on the lumbar spine. So this is a T2 without fat saturation. This is a T2 with fat saturation right there. It's in STIR, steer sequence. And this is a T1 right there. So obese. Her lumbar spine seems quite normal. There is no signs of dehydration of the discs, just a little bit right here, maybe something right here and a bit here, but it's very common at her age, so nothing major. I know you guys have seen this already. These are a few meningeal cysts, nothing major. There is some not destruction, but there is some deformity of the sacral canal. This is quite common because this is a slow growing persistent lesion. Just going to write that down. It's 4.7 by 2.0. All right. Yep. And there is no protrusion or extrusion. The spine, the medulla, the spinal cord is well positioned. The nerve roots as well. Oh, I'm so sleepy. I'm sorry. It's been a rough night. So there is hypertrophy and fat infiltration of the perivertebral muscles. This is a sign of, could be a sign of chronic denervation if we had any features of nerve root damage, compression, inflammation on any of those segments, on the upper segments before these muscle features show up. But we have here two signs of painful lumbar spine, which are degenerative disease of the facet joints. As you guys can see, there is sclerosis, small osteophytes, and hypertrophy of the facet joints. And we have fluid accumulation. We have joint effusion right there on most segments of the lumbar spine, which are easier to see here on the STIR, the steer sequence. Right there. Right there. See? That is joint effusion. That is a sign of synovitis or hypermobility or overload of such joints, since they also show signs of degenerative disease, of arthrosis, mild arthrosis. We can say this is probably the cause of the pain the patient is complaining about. Also, I have a slight edema of the interspinal ligaments right there on L5, L4, L5, S1. From L5 to S1 right there. This is quite normal. This is a bit too bright. Remember, you can't really tell on anything else than the fat saturated sequence, because fat and liquid are quite similar, so it's hard to tell unless you have fat saturation. Hello, Holden. Welcome. What's up, mate? So let's go for arthrosis, synovitis, and slight edema, and this meningeal cyst right there, and we should be good to go to the next exam. So I will also have hypertrophy of the perivertebral muscles. And I have to describe the cyst. Inside the sacral canal. So let's summarize. Mild arthrosis and synovitis of facet joints. Edema of the interspinal spinal ligaments from L3, from L4 to S1. Just copy and paste and remove a few words because it's easier. And hypertrophy of perivertebral muscles. And we are done. I guess we can tell this patient has indeed been suffering of lumbar pain, just as she says. Nothing major, nothing surgical, just regular overload of the spine. So this is quite different. This is a 70-year-old female. This is a brain CT scan. It says she has headaches. So it's a 70-year-old female with headaches. Should be something else. And whatever the doctor says in the exam request, it's I'm unable to read because it's just a bunch of I don't know how to say that in English, so I'll keep it to myself, but it's bad. I ain't show you this, but I guess you can guess. how bad a doctor's writing can get when they don't feel like working. So a 70-year-old female. This is quite a well-preserved brain parenchyma. This really doesn't look like your regular 70-year-old. It's very well-preserved, very healthy brain. Look at that pons, look at that hypophysis. Such a beautiful pituitary gland. There isn't even a sign of acute sinusitis. So it looks very nice. Very, very nice. T2 shows more anatomy. If this were a proper exam, this is of poor quality, lots of noise, lots of artifacts of some kind, maybe just an old coil, improper calibration, but I can't really tell if there is anything wrong with these sequences other than poor quality of scanning. So this is diffusion weighted, looking for restricted diffusion signs which are bright. It looks normal. So flare, T2 is flare is a T2 with an additional pulse, inversion recovery pulse that makes all liquid black unless it's pathology. So if it's pathological, it's bright. If it isn't, it's black. T2 is best for anatomy and flare is best for pathology. So diffusion is here. This is the T2 effect of the diffusion sequence. And this is the proper diffusion weighted image. So it looks fine. The tracts are always a bit brighter. You can follow up and down the tract, hence tractography sequences. And this is a gradient echo, most probably a gradient echo sequence. This is a T2 star sequence that is weighted for mineral deposits and blood product scarring and deposits. So there is no signs of that. This is a normal sequence. Let's see if it was, oh, this is an SWY, not a gradient echo. This is a proper sequence. We have also a coronal scan, which is terrible because this is a 5 millimeter coronal sequence. It's kind of useless, but no, it is what it is. Hippocampus seem fine, just as the rest of the brain also looks fine. This is stupid, no contrast enhancement. So for a 70-year-old female patient, this scan is absolutely normal. There really isn't much to be said. There is no contrast enhancement, there is no proper clinical history, and no previous exams for comparison. So we are done. I'm just going to copy and paste my template of a normal exam, and we are going to go for the next one. Right there. If you guys are enjoying this live stream, don't forget to hit that like button and consider subscribing to the channel. And thank you so much. It goes a long way on helping the channel grow, since YouTube is a bitch. and it just won't push my videos no matter what I do. Specialists say it's like that. I should keep posting and should keep streaming because it will eventually make sense. I don't know. I hope so. So this is a 26-year-old male patient. He says, let's see what he said. Whatever he said, I can't read because it's impossible to read. It's badly written. Let's see what his doctor said. He has bilateral lower back pain. So bilateral lower back pain in a 26-year-old male. Let's grab a normal template for lumbar spine because it's most probably normal. Let me just check if the stream quality, if the stream help is doing fine. Is it doing fine? How is it? Yeah, it says excellent. And we've been streaming for 21 minutes already. I guess we're fine. I guess that's how it's supposed to be. Let's go. Yeah. So discs look fine. This is a T2, this is a T1. T1 is better for bone and for anatomy, and T2 is best for nerve roots and spinal cord, and of course pathology. So it's okie dokie. This little dehydration of the discs is okay. No protrusions, no end plate deformities, no signs of degenerative disease of the bone. Let's see in axial view to look for thickening of the yellow ligaments and hypertrophy, arthrosis of facet joints. I see some accumulation of fluid on this joint right there, and of course the technician decided the lumbar spine should end right there and not right here, so he made a half scan of this segment. Why not? It's okay. It's okay to scan D12L1. Is it D12L1? 12. It's 1, 2, 3, 4. Oh, he missed at 1, 2, 3, 4, 5. He missed 1, started too low and ended too soon. No. I could curse. I could send this exam back. I could waste my time complaining about it, or I could just report it as it is and be on my way taking care of my own life. So I always choose most of the time I choose the higher path. I try to. So there is some fluid accumulation right there. We can't really see that on the axial view because this is a very badly done axial sequence. It's very poorly done. The slices are too thick and they are malpositioned. So it is what it is, but I can see it right there on the STIR, the steer sequence, the fat saturation water weighted sequence, that there is some accumulation of liquid right there and right there and right there. So it's L3, L4, L4, L5. I could say that on L5S1, not much, but there is most probably a edema of the interspinals, the spinals ligament right there on L5S1. So this is also painful and it could be a justification, a motive for the patient's complaints. So I think there is not enough signs of degenerative disease that could be properly classified as arthrosis, but there is some signs of hypermobility or synovitis, acute inflammation of these joints right there. So let's finish this up. Facet joints have proper morphology, but they are filled with liquid. Yep. And the slight edema of the interspinal ligament right there. This is quite painful. Or about the perivertebral muscles, they seem fine, no hypertrophy here. This isn't really a fat patient. This patient is quite slim, so there isn't much overload, at least not in that sense, in this spine. So this is a very mild disease. Usually just medication and physical therapy is enough for a proper recovery. Recovery. Oh boy, I could have some coffee now, but the coffee machine is so far away. I'm not into going there. Let's just report a few more exams. This is a female patient. She is 50 years of age, and it says, I hope it says anything really. It says something I can't really read because this is in proper writing. I don't know how people can live with such writing. Come on, this is just stupid. You write down stuff no one can read. Why the hell are you wasting paper and pen, ink, writing like that? It says headaches. She has some kind of headaches for the last 6 months. So let's go with that, because I'll never guess this writing. This is just impossible to understand. Was there any contrast enhancement? No contrast enhancement. So I'll grab a non-contrast enhanced normal brain MRI template, because reasons, why not? Yep, there it is. You guys can see because it's not legal to show. It's not an animals, and it's in Portuguese, so I guess no matter, it wouldn't matter much because it's not in English. It's Portuguese. Yes, there is a reason I speak such a terrible English. I'm not native. And there is some reduction, some decrease in size of the pituitary gland right there. Invagination of the diaphragm, and the Turkish cell is filled with liquid. Cerebrospinal fluid. And this is a flare. A T2 with a pulse to saturate proper normal liquid, and this is normal, just a occipital horn being shiny as much as the frontal horns enjoy being shiny. This isn't disease, this is normal. The brain has a proper volume. The cerebellum is fine, the fourth ventricle as well. I can't really say. It's... Oh, I'm sorry. Excuse me. So this is a T2 weighted axial image. This is quite like this, just without the inversion recovery pose. For normal liquid, this is best for anatomy. And some pathologies. So mastoids are fine. Orbits, patient has artificial lens. That's fine. We are all going to have, if we live long enough. So especially people like us who watch too much TV, stare at screens all day. And diffusion weighted sequence. Let's see if there is any signs of acute water diffusion restriction more than what is expected for normal brain parenchyma. No signs of stroke, no signs of restricted diffusion, increase in areas of increased diffusion restriction. This is the ADC map, which is useless if we have a normal diffusion weighted sequence. In this case, of course, in some cases, the ADC map itself is the best reference. And this is a SWY, a susceptibility artifact weighted image. This is for mineral deposits and calcifications and old bleeds and tumors. This could be a slight calcification right there. This is extra axial, so I'm not going to report it. It makes no sense. This is a normal brain. A coronal. To check for hippocampus anomalies. No hippocampal anything. So this is a normal MRI scan. I know it's not fun, but I'm not faking it. I'm reporting as I go, and you guys are here with me as we do it. So let's go for a combo of spines MRIs. This is a dorsal spine, a thoracic spine, and a lumbosacral, a lumbar spine right there. It's here. I have downloaded. Yep. Oh, see, you guys wanted a crappy scan, a very poorly done scan. There you guys go. The guy made it. They made it. I don't know. I can't really. Oh, come on. It's just stupid, man. You just don't do shit like that. Oh my. Who is doing these scans? Come on. This is just stupid. And it's unfinished. They made some kind of sagittal bizarre sequence of the entire spine, and they made no axial acquisitions. This is just stupid. Come on. This can't be serious. I'm just going to give it up because there is no axial, and the sagittal clearly half done, so I can't report this exam like this. It's impossible. It's waste of time. I don't have time to waste, nor you guys have, I suppose. So let's grab another spine MRI. It's a lumbar spine, and if it keeps going like this, I'm just going to jump over to the emergency queue and grab some CT scan there to see if we can report anything of use in this live stream, because things aren't looking good right now. Oh, of course. Let's make it as noisy as we can. So this is a 19-year-old male, and I'm just going to waste a couple of minutes trying to read. It can't read. It's not properly written down. And there is lumbar pain. Okay. I don't know why I bothered, but you know, I shouldn't. Let's see. Last I can tell. I guess there is a costal vertebral joint right there. I suppose. Might be. Is it? I don't know. Can't tell because it ends too soon on both sides. This is just stupid. Oh man. Okay. Oh. I don't know if this is a transitional vertebra, because I can't really tell. They made too few slices on the sagittal scans because reasons. No. And it's all noisy and shaky. Of course, why not? So I'm going to say this is proper S1, and anything else from here up is lumbar spine. Can't really tell. It's not properly done. I could just curse, send this back, but I'm going to report it anyway because it won't report itself. I sure hope these exams could be reported by themselves, but they don't. So they pay me to do this. And of course, the technician decided he would only scan 4 of the 5 discs, because why not? No. Let's save some time and make a even worse exam. Yes, this is terrible. And people are paying for these skins. I just whatever. Let's see, there is some dehydration and a extrusion right there on L5S1, and mild dehydration of the other discs, nothing major. I also have some slight signs of arthrosis, and I could tell there is liquid fluid accumulation on some of these facet joints right there. And that is enough to be painful. This patient is quite young, and he already has signs of chronic degenerative disease, which should raise some red flags when he gets back to his physician for follow-up. I have a not normal, but not terrible lumbar spine template. And I'm just going to describe the extrusion. So some arthrosis, mild, and the liquid inside the facet joints. Let's see. Yeah, from L3 to S1, 3, 4, 5, S1, right there. Right there, no vertebral stenosis, just painful features of chronic lumbar spine disease on a 19-year-old male patient. Synovitis, and we are done. Chronic overload goes a long way to destroy your vertebral spine. So let's grab a brain scan. Hit download. It says it's contrast enhanced. This is a 49-year-old female. If it's contrast enhanced, it should be for, it says headaches. So headaches, fine. Okay, so sagittal T1 weighted sequence, and there it is. Axial flare, looking good. The weighting is wrong. It is not a well calibrated scanner, but whatever, it's good enough. T2, regular T2, not flare, seems fine, nothing major, nothing that draws my attention. This is diffusion weighted sequence. A diffusion weighted sequence looks fine, no stroke. Gradient echo, yes indeed, this is a node scanner, no SWUI sequence, just a old T2 star sequence. So no old blood, mineral deposits, or calcifications. They did a sagittal volumetric T1 for contrast enhancement. It's fine. Looks all right. Pituitary gland is okay. Let's just grab an MPR, an axial MPR, and axial view looks fine. Normal. Next step, I'm just going to reassess the flare to be sure there isn't, this is choroid plexus, this isn't disease. Just you guys, if you guys are in doubt, settle down, it's normal. This is also normal. So this is a normal scan, a normal contrast enhanced scan. Just grab my template right there, because why not? And I'm just going to read another scan, and we are going to end this stream because I have to pick up my kids from English school, and they get out at 10 and it's already 9:41. Yes, that is a exam from yesterday that they are asking me to see if there is signs of obstructive bowel disease, and I have already reported this scan yesterday, and they did some stupid contrast, oral contrast sequence on a 91-year-old female. That makes no freaking sense. And I'm just going to say whatever they want to hear, because it's just that stupid. You don't do contrast, oral contrast, to a patient that can't have food nor liquid because she has a obstructive acute abdomen. How can you feed contrast to a obstructed bowel? It's just that stupid, but people do it. I don't care. I'm through with trying to explain anything to people that just won't listen. So and we are done. Let's grab a proper exam. Another brain scan, because it seems we are having more normal brain scans than anything else today. That's really not routine. I hope you guys are enjoying yourselves, because this is just a day-to-day routine to me. It's downloading. And Sagittal T1. This is a female, 41 years of age. This is a contrast enhanced MRI scan of the brain. And we have, I don't know, it says nothing. I'm supposed to guess. So let's guess why this scan was performed, was done, was made, because there is no clinical history. Pituitary gland is a bit smaller than usual, but it's okay for 41. This is an axial flare. There is some bright spots right there. There is a large spot right there and another large spot like that. Right there. Yep. Occipital lobe. Maybe. Yeah. Right there. Parietal, inferior, parietal lobe. And right there on the frontal parietal region on the left. It's right here. Yes, there is some kind of acute disease right there. Let's see if it's bright on C2. It should be, yes. It should be, and it has some kind of nodularity, some odd looking image right there. It's on the subcortical white matter, but the periphery of it has some effect on the cortex as well. And let's see if I can say the same about that other small lesion right there. No, this is quite homogeneous. Is there anything else? These are the two major sites. I have no clinical history, so I won't do a very complex guesswork because I will be wrong no matter how much I push myself. So this is a bit brighter than what it's supposed to be, and the inside of that other lesion is also a bit brighter than it's supposed to be. On right there, this isn't showing up in flare. And this is the diffusion weighted. Let's grab a ADC map. ADC map is here. Let's see if this is shown as a black spot on the ADC map. It's not. Yeah, it's a bit darker than normal white matter, so it is restricted diffusion, mild restricted diffusion, right there and right there. So this is starting to look like a secondary metastatic disease. I wish I had clinical history, but we don't have any. We're just going for guesswork here. So guess away. I'm going to do an MPR of the post-contrast volumetric T1 with contrast enhancement right there, so I can localize the lesion on this very thick flare and see it enhance right there. So this is an enhancing lesion, and right there yet another enhancing lesion, intra-axial enhancing lesion right there, and there is marginal edema. So heterogeneous, it's bright on T2 and flare, hypointense in T1, it enhances, and it has a signs of restricted diffusion and no clinical history, but I would go firstly with secondary disease at her age group, 41, could be anything, breast cancer, could be spinous epithelial cancer, it could be lung cancer also, gastric and esophageal cancer could be, but I couldn't say because there isn't any clinical history whatsoever. So I'm just going to describe the lesions and be on my way because we won't go anywhere. I'm just going to measure this 0.8, and this is a 1.0. So let's grab a normal template for starters. Normal template. And delete the diffusion weighted sequence and the non-enhanced lesions sequence. And let's describe the lesions. So they are solid, intraaxial, they have peripheral edema, and they enhance. This is it. This is the pre-central gyrus. Pre-central gyrus. Yes. So let me just read what I just wrote. Two lesions, ill-defined, heterogeneous, intraaxial, contrast enhancement, adjacent edema, marginal edema, 1.0, 0.8. And we are out. So I guess this is it. Thank you so much for watching. If you enjoyed this live stream, hit that like button, subscribe to the channel so you won't miss the next time I'm online, I'm live. I'm trying to make it at least 3 times a week. I'll probably do a live stream sometime soon from Mondays to Fridays because I work from home and the office from Sunday to Sunday. I don't have 3 days. I work from home I do this every day. Sometimes, most of the times, the live streams aren't this boring. I usually have a lot of CT scans from the emergency. These were mostly uh, outpatient MRIs. So thank you guys. Hit that like button and I'll see you in the next stream. So long.